Hello, this is John Kanellopoulos from Athens, Greece, clinical professor at NYU Medical School, New York, and I'll show you our technique of YAG capsulotomy. This is a 35-year-old female who had significant myopia and significant cataract. She's 2 years now pseudophakic. You can see the dense organization of the posterior capsule here, and my preferred technique is to go vertically, starting at the top of the posterior capsule, cross through the center, and you're seeing as I'm progressing here inferiorly, this is a very dense posterior capsule. I use the Zeiss neodymium YAG capsulotomy device set at 2.2 joules. Patient is a little bit moving, but nevertheless, you can see how this laser uses the 4 dots focused onto one, and this is the Heaney guide for the surgeon to adjust the. You can see how the posterior capsule cracked open here once the fibrotic area was released. And again, we're just inferior to the center of the posterior capsule, and you can see how dense, and again you saw here how posterior capsule cracked open. It was not surprising that in this patient capsule opacification induced an extradopter myopia because it appears to move the lens forward. Now I'm going horizontally from the center towards my left, towards the patient's right, nasally. This is the left eye we're treating. And you can see again not only the poor fixation with the patient, but also the areas that we're going to try and treat. Again, here the 4 guiding Heaneys focusing into one, and then press the laser button and create a track, a radial track from center to periphery. There is a group of ophthalmologists that prefers to do a can opener posterior chamber capsulotomy. I prefer this technique, the vertical line going from superior to inferior, and then extending each temporal and nasal radial horizontal line from the center out, because I feel there's less spots needed this way, and also that the 4 quadrants of free capsular tags that are created, posterior capsular tags with time, contract and create a nice round or oval capsulotomy. I'm going now and I'm bisecting each one of those 4 quads inferiorly because, as you can appreciate, the posterior capsule here is extremely dense, but it's behaving well. Able to successfully incise the posterior capsule, and we're all in gratitude to the original work done in France with YAG capsulotomy, as this procedure several decades ago would obviously demand a re-op in the operating room and manual cleaning of the posterior capsule. So we're going here slowly and methodically to clear the central part of the lens, and you can see how effective posterior capsule YAG incision is in today's technology. This is the other eye and some phimosis on the anterior chamber in the other eye, which we'll describe later. Hope you found this presentation interesting. John Kanellopoulos signing out. Thank you very much for your attention.